Hello, and thank you for joining us today. I'd like to welcome you to our show. We're going to explore the importance of relationships in the healthcare supply chain setting, actually a specific type of relationships, spotlighting physicians and suppliers and how their interaction feeds into impacting the total cost of care, as well as managing a transparent and sustainable supply chain operation. This is actually a two-part series. Today, we're going to speak with a couple of experts in the field who've been working with physicians, clinical staff, and suppliers for the past several years. And then next month, we're actually going to hear from a healthcare organization and their CFO on how they're managing this dynamic to really maintain a clinically aligned supply chain. So let's start by meeting our presenters. Doug, could you tell us a little bit about yourself, please?
Absolutely. Thanks, Justin. So Doug Byamborn, I've spent over 30 years in cardiovascular diseases, anywhere from cardiac surgery to interventional cardiology to medical care of patients. Prior to joining Vizient, I also did things as starting new clinical programs, and one of the clinical programs I started was ER care for atrial fibrillation and syncope. I've been with Vizient for 4 years now, and in my current role, I spend a lot of my time looking at the total cost of care and what we can do to improve healthcare and reduce its cost at the same time. Thanks.
Thanks. Thank you, Doug. And I've had a chance to work with you a lot more recently and really appreciate your contributions. Lucretia, could you tell us a little bit about your background?
All right, thank you. I'm Lucretia Little. I am a clinician with over 30 years experience in healthcare. I've been with Vizient about 11 years working in the clinical consulting team, mostly in the musculoskeletal areas, which includes orthopedics and neuroscience, helping hospitals in those, helping service lines in those areas to reduce their total cost of care. I'm glad to be here today.
Yeah, thanks, Lucretia. I know you got a lot of great experience and ideas you're going to share with us today. So thank you both for being here and looking forward to this discussion. From an agenda standpoint, we're going to review and explore really 4 key areas that relate to our topic. First, we're going to look at some drivers of success. So what are the fundamental elements needed to really manage this dynamic appropriately and effectively? Then, while you've identified the need, how do you go about developing more of a partnership approach? And the idea is that your staff and your supply partners are aligned and doing really what's best and what's right for your organization. Then as we lay the ground rules out, so to speak, let's look at an example of how this can be deployed and then really finally look at some additional resources for reference. Now, just to keep things fair, we're going to bounce back and forth between our 2 speakers today, letting them weigh in on the topics and really share their personal stories. But before we get started, we are seeking your input. And if you could just take 5 seconds to review and respond to this question, we'd like to know what you feel is most important when driving a clinical preference item initiative. Now, I know that most of you want to say all of the above, right? But that's the easy way out. We want you to tell us the most important thing. So what do you feel is the most important aspect from one of those options listed there? All right. Okay, very good. So Lucretia, let's start with you if that's okay. In normal times, let's just call that pre-COVID. I know this idea of managing the relationships between suppliers and physicians, even clinicians, is dynamic, I guess you might say. But based on your experience working with members in hospitals across the country, we've seen these items listed here as crucial to really get that sustainable success. Can you walk us through these drivers and then maybe elaborate on your perspective and how it impacts the total cost of care?
Okay, yes. So with the work that me and my colleagues really do with provider organizations, we've determined that there's really 5 key drivers to a successful initiative. And the more of those key drivers you have, the greater your success. And so when we talk about having an executive champion, is having having that executive level engagement and support throughout the life cycle of the initiative. That executive champion really ensures that there is alignment to the overall enterprise goals. And they are also really truly, they serve sometimes as that conduit between to the physicians with that constant communication. Engaging the physicians in the process is really key. They are the frontline decision makers for the products and services that are used to optimize the care for the patient. You know, identifying a physician champion as early on in the process is key because they represent or become the conduit between the provider organization and their peers. And they will represent those physicians throughout the process. A physician champion can be either a formal leader like a medical director, or it could be a high volume doctor or physician or someone who has influence among their peers. When we talk about reinvestment, so we, have a willingness to incentivize your physicians to participate in initiative. And when I say incentivize, it is not talking about a financial incentive, so not a formal co-management arrangement or a gain sharing arrangement. Really talk about reinvesting part of the savings that is achieved back into the program for improvements. Some examples of those kinds of improvements is like staff training, improve efficiencies or increase efficiencies around cleaning and sterilizing instrument trays, or improving the process to increase or decrease your turnaround times. Or it could just be things like the physicians want more block time, or they want the ability to maximize the block time they have. Sharing data. So data is a catalyst to change. And so most or all important decisions are really based on reliable and consistent data. And so when you can share clinical data like length of stay, mortality rates, OR times, financial data like reimbursement, profitability, contribution margins, payer mix, both at the program level and the physician level is really key. And then, of course, sharing the actual cost, that procurement cost for those products and services is key. When physicians understand the cost of their decisions, they tend to make better decisions. And then the final key driver to success is that willingness to make a change. And when we call it making a tough decision. That is organizations' willingness to part ways with a non-compliant vendor or supplier. That means that's the reason why it's important to engage those physicians. They are the ones who are selecting the products from the suppliers. And if you have to move away from a non-compliant supplier, then the physicians have been a part of that decision making. That's the reason why it is very important to actively establish long-term, mutually beneficial strategic partnerships. A lot of times, provider organizations, they only have what we would call transactional relationships with their suppliers. It means they only talk to their suppliers when there's a problem with a billing issue question, or it's time to renew a contract. That's that transactional relationship. So we encourage a strategic partnership.
Nice, good. And Doug, from the supplier's perspective, what have you seen or heard? What are those who are seeing the greatest success doing to elevate their support, right now in our current state?
Yeah, hospitals are really trying to look for strategic partners in industry. And then, there's value beyond just the price of the widget. Not that the price of the widget will ever go away, but there's other values. So we look at things such as risk share programs, best practice models. Does the device that this manufacturer is selling, does it have white papers to support both short and long-term outcomes, that it improves patient care? And then another person to put in this whole equation is the patient themselves. What is their satisfaction with the care and the supply that was used on them, specifically like a pacemaker, defibrillator, orthopedic products, things like that can directly change outcomes. So when you put all that data together, and as Lucretia talked about, the data is really, being able to have actionable data by, what physicians are doing, what their outcomes are, efficiencies, that's really what the hospital is looking at, and how do you put that whole program together to get the best clinical program that you have that's efficient, best outcomes, and cost less.
Good. Okay. Great. Now, I guess that what this slide is really telling you, Lucretia, is that, you don't really want to pick and choose. You want to do kind of everything, right?
That is correct. What we've done, as I stated earlier, with the work we do with provider organizations, we surveyed, and that we found essentially to achieve the greatest amount of savings or to achieve more than what you targeted, you really need all 5 of the drivers. And this slide truly represents organizations that had all 5 of the key drivers. They achieved more. And then as they didn't have a driver, they didn't achieve as much savings as they thought they would. But some other key factors that we believe are really crucial to having a success is adhering to aggressive timeline, maintaining that consistent communication. And then the one factor that sometimes hinders the progress within an initiative is really not understanding or establishing a process for addressing physicians' conflicts of interest. When I talk about conflicts of interest, is there formal or informal relationships with their suppliers? So a formal relationship would be some kind of royalties or consulting arrangement, or informal relationships is the son-in-law is the rep that works with him in the room.
Yeah, that's true. I've heard stories about that kind of stuff before. Let's maybe go back to physician engagement for a minute. And, as I mentioned previously, our second part of our series is going to highlight a specific example of how St. Charles engaged their physicians during our December webinar in detail, our second part of the series. And one of the things we learned in speaking with that team is that each and every initiative is different, right? And each surgeon is different. Lucretia, has that been your experience as well?
That is right. But the key is really engaging those physicians. The physicians is more like your ace if you're playing cards. They are the key to success. And with physician preference items, or what we would consider clinically sensitive categories, they are more complex and they require a higher level of coordination and collaboration between the physicians. Hence the reason why you need to engage them. But working with the physicians, though, it established credibility, because you're sharing that relevant data, so that data I talked about earlier. You're using the physicians for their input and expertise. They are the individuals that are using these supplies and services, so you have to use them to help develop that strategy. The worst thing you want to do is put a strategy in place that your physicians don't support. And this engaging the physicians really and truly creates or foster a collaborative environment. The physicians are involved in the decision making, so they're not being told what you're going to do, but being a part of deciding what we will do together. And then the continuous communication promotes transparency. That everybody is in the know of what's going on and there's no surprises.
Nice. Good. Okay. Very good. Thank you for that elaboration and sharing that. So, hey, guess what? It's poll time again. Now, this question doesn't really lend itself to all of the above option, but if we could get your feedback again, how clinically integrated is your supply chain? Now, this is blinded, so we're not going to out anybody, or we're not. You can be very honest in your answer here, but just let us know. How integrated you believe that your supply chain is. And, really, and Lucretia, in your experience, maybe I'll call on you one more time, but for those in maybe the C and D area, the moderately or not very, what should they take away from this broadcast today?
They really should take away looking at how they can leverage those 5 drivers. And so that's how you become more clinically integrated. You have to have all those key stakeholders, all the data to support that change that you want to do. So that's one of the key takeaways I would say from this section.
Good. Okay, great. All right. Well, Doug, I'm going to get you to elaborate a bit. Lucretia mentioned the importance of fostering collaborative environment. And one of those examples of a program that benefits from such a structure, we actually featured it in our fall Tech Watch publication, was the Cryptogenic stroke care. Could you walk us through maybe how approaching this from a total cost of care perspective has a positive impact on both patients and facilities?
Absolutely. So on the right-hand side, we have the patient and we have the care model built around it, all the people that are involved, and this is a short list. And as Lucretius, pointed out, it's really a team effort. You have to have all the people that are involved in the care model that are going to be stakeholders in these process of improving patient care as being a part of this. So one of the programs that we've rolled out recently is regarding cryptogenic stroke. So just a little bit of background on strokes in general. So about 800,000 strokes occur each year in the United States. It costs the U.S. healthcare system about $45 billion, so it's a large impact to our society. It accounts to about one stroke every 40 seconds, so it's mind-boggling how many there are. In the end, with the cryptogenic stroke program, there's about 175,000 people are diagnosed with a cryptogenic stroke. And the question is what is a cryptogenic stroke? So a cryptogenic stroke is a stroke that occurs that we know that there was a blockage of some sort in the vessel, but we don't know what the cause of it was. It could be from atrial fibrillation. It could be from a heart structure disorder. It could be from clotting disorders, or it can be from a large plaque rupture. But after all the testing's done, including CTs, MRIs, blood clotting disorders, cardiac imaging, they don't have a firm diagnosis at time of dismissal. So about 175,000 people get bucketed into this each year. And with that, with a diagnosis of cryptogenic stroke, you are at high risk for a recurrent stroke. So it really is important, even after the patient's dismissed, to be able to get a firm diagnosis for these people that have cryptogenic strokes. So, when we look at this program, it's like, what is the process of diagnosing these patients? What testing are they getting done? How can we shorten the length of stay? But then how do we improve the outcomes and clinical diagnosis after these patients leave? Next slide. So when you're building these clinical programs around cryptogenic stroke and best care models, and you bring in the physicians, you bring in the C-suite, you bring in all the different clinical entities that touch these patients, you have to be able to work at this and be able to see what the opportunity is and what the problems are. So one of the first parts of this process is just bringing the cardiologists and neurologists together. It's amazing, these subspecialties don't work together that often, and when you bring them together in the same room to be able to assess what the opportunity and what the problems are, they really enjoy working together. So the first part of this is just bringing those two people together, and then being able to create the key stakeholder team. So it includes the physicians. You want the C-suite approval for being able to look at this process. You bring supply chain in, looking at all the opportunities there. You also want to look at the reimbursement process of this, because there's different DRGs that include CCs and MCCs, and you want to be able to code appropriately for these patients. One way of looking, one thing that you'll need to look at is what the population is that has strokes in your institution each year. So what you do is there's 3 medical DRGs and 3 surgical DRGs, which are listed below, DRG 64, 65, 66, as well as 40, 41, and 42. And you combine those together, and that's your total stroke patients that you're dealing with each year. And approximately 25% of those will be cryptogenic in nature. So that's your opportunity to be able to take care of that patient population. The one thing that we've been enrolling into these patients is use of implantable loop recorders. So when these patients go home without a clear diagnosis of stroke, these implantable loop recorders are able to detect arrhythmias, both atrial fibrillation and other, to appropriately care for patients if that is their problem. And if you find that there's a problem and you can do this remotely, then you can properly diagnose those patients and be able to get them on the right treatment pathway. So it's really important to be able to see what your penetration rate of use of implantable loop recorders and cryptogenic stroke by looking at CPT codes, and also being able to look at the diagnosis associated with the use of that implantable loop recorder. And then it's really important when you look at the total cost of care, it's like, what's the length of stay? What's the variances between physicians? Are some physicians do more interventional procedures than others? And then be able to both look at short and long-term outcomes, and then recurrent rates of stroke with those this population. So you're looking at the big picture of this total stroke care. And, and one of the other things that's really important with all these is to make sure that you're getting reimbursed for your services that you're properly delivering. And so, as you can see just below, the weighted average for a medical care for a cryptogenic stroke patients or any stroke patients is, $7,686 when you put all those three DRGs together, whereas if they go with the surgical side, the reimbursement $17,414. So it's almost a $10,000 difference if you code this incorrectly. So it's really important to have the reimbursement people as part of your team and to be able to look at the total model of care. So with these cryptogenic stroke pathways that we've developed, we've taken a look at, what's the opportunity, what's the current penetration of use for implantable loop recorders, what's the reimbursement look like, and most importantly, being able to bring that total team member together to be able to find out what the best care model is.
Good. All right, that's really interesting. Thank you for sharing that, especially that description. We are almost out of time. We do have time, however, for a few questions. Anyone who's participating can enter that in the chat session over there. We did receive one, and I know in our first polling question, it looked like physician engagement was seen as the most important. But maybe, Lucretia, what are physicians skeptical about some of this? I mean, what do you hear from them?
Of course, they're skeptical about things like this, and what it ends up being they're concerned that they're not going to be able to have available to them what they want to use. And they will say that it's because they want these products for their patients, but in fact, it is really physician preference on those items, and they're afraid that they won't have that. And so they use things to sometimes undermine or discredit the data. And so that's the reason why it's important for you to share data regularly with the physicians that is reliable and credible. And so then it can promote dialogue amongst their peers. So make sure it's a conversation that the physician peers are having about a change, and it's not being a directive, but more collaborative. Gotcha.
Okay. Perfect. And sorry, for those of you, please submit your questions via the Q&A panel. Sorry, not the chat. My bad. Doug, hey, I like when you say loop recorders. I think that's a neat word to say. Are the implantable loop recorders, are those covered in the cost of care for the stroke and what we're talking about?
Hey, Justin, that's a really good question. I mean, most physicians are a bit confused with that. I mean, obviously, there's a cost of implantable loop recorders, and in some practices will say, I'm just going to lose $4,500 on a patient if I implant this loop recorder. Well, the interesting thing in the cryptogenic stroke, or even in the stroke population, is patients that are implanted with an implantable loop recorder go from a medical DRG to a surgical DRG. So you can see the difference in that. In the one slide was $10,000 difference nearly in payment. So you're able to provide the best care for that patient. You're able to implant that device while they're hospitalized. And then the other question would be, is it covered by Medicare? And the answer is yes. So Medicare does cover the implantable loop recorders, and you can do it at time of stroke. And what some hospitals are finding is they're able to get the patients out on average a half a day to a day earlier, because many of these hospitals are just continuously monitoring patients to see if they have atrial fibrillation. And after 2 or 3 days, if they haven't found it, they can put this device in and send the patient home and still be able to pick up that diagnosis if the patient has atrial fibrillation later.
Wow. Okay. Good. Okay. Excellent. Well, thank you guys. So this is the end. I thought this was one of our best webcasts that we've had today. Very informative. Thought the content was excellent. Really appreciate both of you for sharing and also allowing us to really tap into your expertise out there. As a reminder, our second webinar on this subject, which does feature a hospital and their executive team talking through how they're really following and implementing some of these principles that we talked about today. That's going to take place in December, so please register for that. That will be Tuesday, December 8th. Also, we encourage you to read our article in the recent Tech Watch about the strokes. And you can visit the public website for more information, or you can also contact me as well. So thank you again, everyone, for joining us today, and I appreciate the discussion. Thank you.